Recording now. All right, welcome to our webinar, everybody. I'm Tegan Orr. The title of this presentation is Understanding Functional Limitations and the Role of Occupational Therapy in POTS. And we're really happy to have Emily back. For anyone that doesn't know, she also gave a really awesome talk during our conference last summer. So I'd like to now introduce our guest speaker, Emily Rich. She's an occupational therapist serving adolescents and adults in an outpatient therapy setting at Tucson Medical Center in Arizona. She specializes in treating individuals with chronic conditions, including forms of dysautonomia, such as POTS, postural orthostatic tachycardia syndrome, and Ehlers-Danlos syndromes. Emily is pursuing her PhD in occupational therapy at Texas Women's University, and her research centers around POTS and rehabilitative interventions. So welcome, Emily, go ahead.
Thank you so much, Tegan, for that introduction. Like she said, I'm Emily. I'll be speaking today on a study that we did, a survey study, and then also some information just generally about occupational therapy in POTS. So as Tegan mentioned, I work in Tucson, Arizona. That's where I practice as a therapist, and I'm also in school at Texas Women's University, and I have nothing to disclose. So this is the journal article that we'll be discussing today. And so a little bit about this study. It was, we developed a survey based on a pilot survey that we had questions about functioning in POTS. So it had information about falls, experiences of therapy, daily life function, and the use of different strategies for treating their symptoms. And Dysautonomia International was kind enough to share the link to this follow-up survey with their followers on Facebook. And we left the survey up for 10 days, and the criteria to participate was you had to have POTS, you had to be between the ages of 18 to 60, and it had to be the person with POTS who was taking the survey. And so we received a total of 958 completed surveys in that 10 days with an average age of 32 years old, and the majority were white women. So we were very excited about this response with how many we got. The survey had a variety of types of questions, including multiple choice, multiple select, and then open-ended questions. And here in this article, we only talk about the close-ended multiple choice type of questions. So the aims of this study were to examine the impact of POTS on different aspects of daily life, which occupational therapists call those occupations. So anything you do in your daily life. To identify treatment strategies that people use to compensate, to quantify or put a number on how many people experience cognitive impairment and also falls, to better understand the use of self-management strategies, and to quantify the use of rehab, such as occupational or physical therapy. As I mentioned, the majority of individuals were female and Caucasian. Most were employed in work or as a student, either full-time or part-time. And then there was a percentage who were unable to work or were retired. And nearly 3/4 of our participants had at least some college or a college degree. And so here you'll see our first question that we'll discuss. So these responses were regarding this question of what's your overall function like, where 1 represents an inability to do anything that a person wants to do or needs to do in their daily life, and where 10 is that they're able to do everything that they want to do or need to do. And so you can see the different numbers and the percentages there, but 61% overall rated their current level of function at that level of 5 or less. So kind of like a 50% function or 50% disability or less, which is quite substantial. And then we wanted to better understand which specific areas of daily life are impacted by POTS symptoms. And so basic activities of living were significantly impacted, as you can see on the left here. And based on our preliminary pilot survey, we combined several activities into a morning routine and getting out of bed in the morning. Because we saw that activities like brushing your teeth or putting your clothes on were not necessarily challenging. More of that idea of putting all of these things together, which probably resonates with some of you listening, of trying to do all of those things, the standing, the up and down, and the demands together. So that's why we have those categories on here. And so the most impacted was bathing or showering, followed by getting out of bed in the morning, which both impacted around 3/4 of our participants. And then even the least impacted, which was sexual activities, impacted half of participants. And then in the instrumental activities of daily living, those are kind of like home management and raising children, those kinds of things you see listed. Home management affected 85% of the people taking the survey. So that includes cleaning and things that you need to do, yard work around the home. And so then this was followed by shopping and meal preparation, which also impacted about 3/4 of participants. Community mobility is like taking the bus or navigating to a local store, being able to move around your community. And that coupled with driving was about 60%. And keep in mind that not everyone attends religious or spiritual activities, and not everyone has children. And so these numbers represent only those who they applied to. And so I think that 20% and that 30%, or you can think about those in the context of who they apply to. All right, and then the other areas of life that we looked at included leisure or hobbies, sleep, and socializing. And those were all highly affected, that's 73, 75%. And then again, education and work were impacted, but again, not affecting everyone. Not everyone's in school, not everyone is at the age of working, since these went down to 18-year-olds and up to 60-year-olds. So yeah, if we were to narrow it down to just a school age population or just a working age population, those numbers might be higher. And then we wanted to quantify cognitive challenges, and we went on to ask some more questions that were more open-ended about what do those cognitive challenges look like, trying to understand them better, as this is an area of interest of mine, and there's just not a lot that we know about treatment for cognition. And so specifically we asked, in the last week, have you had challenges with thinking, like that cloudiness or fogginess in the last week? And so the result was that 93.4% of participants reported difficulties with that just within a week's time. And there is a separate manuscript or a separate journal article that you can find online where we talk about some of those descriptions of the challenges that people experience, and it might help you, feel like you're not alone, because they're often very, very much shared, the cognitive challenges. One aspect that I was curious to know about was falls, as this has not been previously reported in POTS. So falls can lead to concussions, and as we know, that can exacerbate symptoms of POTS. So although most people with POTS do not have episodes of true syncope or falling and passing out, losing consciousness, but they're more likely to have pre-syncope or near syncope. They also have symptoms of lightheadedness, dizziness, balance or visual disturbances, and leg weakness. And all of those things we know can contribute to a risk of falls. The World Health Organization defines falls as coming to rest inadvertently on the ground or floor or other lower level. And so what that means is, doesn't have to be this dramatic, falling over kind of thing, but just that sense of, you crawl back and need to catch yourself, or you fall into a chair, that is considered a fall, even if it's not fully to the floor or ground. We found that falls occurred in the year prior in more than half of the participants in this study. Of those 55%, 25% of them required medical attention after that fall. And then in terms of treatment strategies, so we did this pilot study and we asked questions and asked people to fill in, what are things that you do and that you use. And from those results, we took the most commonly reported treatments and we put them into this question. And we asked people, choose the top 3 most helpful in managing your symptoms. So you'll see these don't add up to 100%. Because we asked people to pick 3. And if they didn't have 3 that they felt were helpful, then they chose that none of the remaining options were helpful, or I have not tried them. And there were 3 questions for this. So you could select that none for all 3 if you wanted, or 2, or just 1, or 0. So what we found is that you can see, unsurprisingly, the number 1 was increasing salt and fluid, and that was cited the most often. And then the remainder were cited by less than half of people after medications and salt and fluid. And then after that, less than half of people. So exercise, 35% found that to be helpful, followed by compression garments. And then least often was that adaptive equipment, breathing and meditation, and then elevating the head of the bed were not used by very many, or were not found to be effective, or were not used by many. Sort of similarly, but a little different, as we looked at assistive tools. So compression, we considered that a tool in this, but it's also things like mobility devices, wheelchairs, using a chair to sit, which of course that was the most often used here. And again, these are not going to sum to 100. It was the same kind of thing of choosing the ones that are most helpful for you. So using a chair, using compression, a shower chair or a tub bench was used not as often as I would have thought, but I'm an occupational therapist, so I recommend that often. So that was used by 41%, and then the remainder were used by less than 1/5 or 20% of participants. And so that included a variety of mobility devices, which are of course spread out here. So wheelchairs in a separate category than a walker or rollator. And then long handled items, which I'll talk about later, why we would even bring that up. And then temperature regulating devices, those kinds of things. So those cooling towels. And then towards the end, we asked about therapy. And so we asked people, have you ever been referred for therapy services, occupational or physical therapy specifically? And if you've been referred, did you end up going? Did you receive therapy services? We asked questions about how many sessions they had, and then what interventions did the therapists use most often. But here we'll just talk about the fact that only 26.9% of people had any form of OT or PT. Less than 2% had occupational therapy in isolation, and about 4% had both occupational and physical therapy. So that leaves 73% of people with POTS who've never had any type of rehab service specific for POTS. And we did write that, please try and answer these questions specific to your POTS symptoms. We know that lots of people have other conditions like hypermobility or, just a variety of things like a concussion that might have led them to therapy. But this is specific to POTS. So therefore, the biggest takeaways that we found were that an average of 11 areas of daily life were impacted by POTS, and participants had relatively high levels of perceived disability. Cognitive impairment on a weekly basis was reported in the majority of people, and falls occurred in just over half of individuals in the last year. However, therapy services were infrequently used in this population, and therefore we feel like we need new treatment approaches and more training for rehab professionals to increase the potential benefit for this patient population. It's possible we also need more provider education on the medical side to send those referrals. But they need to have therapists that are knowledgeable in order to send those referrals. So that's kind of the state of where we're at based on this study. So we learned quite a bit, and it's really helping to inform my dissertation work that I'm doing going forward. So if you took this survey, thank you so much. And there are 3 manuscripts out at this point, just based on this one survey. And so I think it's really going to help in terms of the amount of literature and therapists' understanding of this condition. So now I want to go into what is it that I do? What is occupational therapy? Most of you are probably familiar with physical therapy, and a lot of people want to know, how is it different? What could this do for me? So when Lauren asked me to speak, she wanted me to include just, some things that occupational therapy might be able to do for a person with POTS. So OT is a rehabilitation discipline, which aims to empower individuals to return to daily life activities. Therefore, occupations are anything that occupies your time. So that includes all of the following activities that are on the slide, and so many more. So you can kind of take a look and see, are there things on there that you feel like, someone would be able to help you with those things if they feel like they're not quite at the level you wish they were at. And then what types of symptoms do occupational therapists address? So we look at all of the symptoms on this slide and more. We really try and look at the whole picture of the person. So we try and focus less on kind of a narrow, you're sent to me for this one thing. And that's why I think it's so perfect for POTS, because it really encompasses so many areas of life. So things like brain fog, fatigue, challenges with sleep or pain, sensory dysregulation, bright lights, loud sounds bother me, that kind of thing. Visual motor challenges or visual perceptual issues, if you get dizzy from just eye movements, or if you're having some difficulty with vision. And then upper body dysfunction. If you have hypermobility, joint hypermobility or Ehlers-Danlos, you should definitely be seeing an occupational therapist, because we do specialize in the upper extremity and fine motor kinds of things. So a lot of the people that I see have both conditions. All right, so in healthcare, we have a term called evidence-based practice. It's a 3-pronged approach to delivering care, where we factor in not only the best research evidence, but also the clinical expertise of the therapist, and importantly, the patient's experience and their values. So that happy medium where evidence-based practices is in the middle there. And so we are developing more research evidence every day. It seems like you've seen POTS in the news lots lately. And Dysautonomia National has so much funding that for great new research projects. But what I'm excited about is I think this study really contributes to our understanding of that patient experience. Of course, each patient is unique and the therapist is going to work with that patient individually. But sometimes if a therapist hasn't met very many patients with POTS, they don't really have a good handle on what it is that OT could do. Or, what is your life kind of like? I tell people sometimes I'll have a patient come in and if you go through the checklist, oh, I can get dressed, I can brush my teeth, I can do these things. But if you ask me to do them all in one day, or if you ask me to do them on a rough day, I'm not going to be able to do them, or if I do that, I can't do something else. And so the therapist might not know to ask you it in that way. And so anyway, I think that this helps to understand better what the life of a patient with POTS is like. So let's start with some adaptive tools. I want to give you some things that you can get a feel for what it is that OT does, and then hopefully you can find someone in your area and they can individualize it a little bit more. So on this slide, you'll see ideas for how to prevent bending down. So bending down often causes symptoms of dizziness. For example, so you might use a long-handled poop scooper, which is in the top left picture. A shoehorn, which is in the bottom, can help you put shoes on and off without having to reach down. And then a long-handled razor, which you can really make long-handled things yourself. If you just take a dowel rod, or, there's a variety of, even taking your broomstick, excuse me, and duct taping it, to whatever you need to use it for. But they do sell long-handled razors just like that. And then you will see some sound buffering earplugs on that upper left picture, the red one, which can be helpful for sensory overstimulation, for example, in the grocery store, or a movie theater, or somewhere where it might be louder concert, can kind of dull that sensation a little bit. You'll see a blue weighted lap pad in that top right picture, which is also a sensory tool, similar to a weighted blanket, but a lap pad is kind of nice because it's small. You can use it when you're sitting up, especially with all the stuff we do on Zoom and things now. And that can help with that grounding input to help you kind of have a sense of where you are in space, and can help with some of that overstimulation. There's a tub bench on the top, which is appropriate choice for a tub shower combination versus just a standing shower stall. And so sitting in the shower can make a huge difference in the amount of energy that you exert taking a shower, and also in terms of dizziness symptoms and things like that, trying to prevent those from happening with blood pooling in a really hot and humid environment. Service dogs can be an amazing tool, and I have a lot of patients that have service dogs, and I think they're becoming more and more used, and people are understanding better and better how they can help. And then compression garments, of course, are often really supportive therapies to facilitate that blood flow, both the full-length leggings and also an abdominal binder. And as Tegan mentioned, I spoke more on a lot of these specifics in the webinar over the summer at the conference. So if you want more information on those, check that out. All right, and then on the left here, you will see a variety of temperature regulating tools. such as hot hands, a portable heater. If you don't have an electric plug, there's even propane propane heaters that you can use that are really small and portable. For the summer, there's cooling towels, and that one that girl has around her neck is a fan, a cooling fan that's just battery operated. And then cooling vests where you can put ice packs in, that kind of thing. On the right side, you'll see different tools. So similarly to preventing bending down, tools for preventing having to reach up overhead, cleaning the house or home management was the most often cited challenge. And so I think these tools are especially relevant. So some people with POTS benefit from using long-handled sponges, for example, to bathe themselves, using that long window cleaner instead of having to reach up overhead where it's harder with the blood flow challenge, keeping your arm down here and reaching up that way. Using a automatic shower cleaner once a week or something to keep the dirt down, and you just press a button and it just sprays around the whole shower. And similarly, this robot vacuum, which I'm a big fan of, I think it can seem, it's hard for some people to kind of spoil themselves with some of these tools, but they can make a huge difference in terms of the day-to-day and week-to-week energy expenditure. On the right, you'll see at the bottom a stand for a hair dryer. So you can look at like freestanding hair dryer or hands-free hair dryer and find those, which can be good with preventing that overhead motion. And then that bottom left on the right side is a compression donning device. So donning meaning putting on. And they also have compression doffing devices. And so these make it a lot easier to get compression socks and compression leggings on. So those are definitely worth looking into, because as most people know, putting on compression is always a game of whether or not it's worth it because of how much energy you have to use. So now I'd just like to go through several different types of activities to give you a sense of what an OT's mind is like when it comes to a challenging activity and our approach to treatment. So as you'll remember, I said home management was the most often cited as impacted by POTS symptoms. And so cleaning can be supported by using various devices, as I mentioned before, like a robot vacuum, adding longer handles to things like a duster or a sponge for cleaning dishes and not having to reach down so far and scrub so much. If a dishwasher is not an option in your home, you can find these countertop dishwashers on that upper right picture. They are quite expensive, but if that's an option for you, if not, then really encourage you to fill the sink with hot soapy water and soak dishes, and just never spend the energy to really scrub something. And then always air dry on a drying rack versus using that extra energy with the towel. In terms of cooking, there are so many different ways that we can modify that. And so an OT can work directly with you on meal planning, meal preparation, not just, oh, you need to use a crock pot or you need to use an air fryer as shown in that picture, but how do you actually make nutritious foods using those devices? What are ways to, chop up fruits and veggies, or do the preparation part of the meal? Because it's not just, put it in the crock pot and pull it out. There's a lot of pieces involved to that. So OTs can help you specifically with that. One little tip that I like to tell people is that there are plastic liners for crock pots or slow cookers, which can really help with the cleanup. Because as we know, it's not just the preparation or the cooking or the eating, it's the cleanup can often be the hardest part. And then some people just need to use paper plates, certain weeks. And I think just it's your own wherever you're at with that. But I think sometimes that's just kind of the way that we have to get by. If a person's experiencing challenges with intimacy or romantic relationships, there's a variety of books that can help with guiding people to different positions or strategies for conserving their energy and limit symptom exacerbation. So one of them, I think it's called, I was going to be at my office doing this, but I didn't, and I have the book there. But if you look up basically like sex and disability or something, and the word disability is usually what helps with finding a lot of these kind of resources. So an OT can help specifically with working with a person individually on their unique needs, or a couple. And then pelvic floor therapists, which are often physical therapists, sometimes occupational therapists, are often helpful, and they might be more readily accessible in your area if you can't find an OT, but that's an area that's really important to you. And so you just would ask someone for a referral to a pelvic floor therapist. Childcare is another example where, it's pretty individualized. There's quite a few social media accounts and parenting with disability books that are available. And again, an OT can specifically cater this. There's a picture there on that top left that's demonstrating some different ways that activities can be modified. So maybe changing the environment, that's a part of what we do, is changing the home environment, and also changing the way that we do the tasks. So she's changing her child from a seated position in a special chair that elevates. I'm so sorry. Of course, my throat, I've been talking all day with patients and I've not had any issues, but of course that happens right now. Okay, and then also there's the Disabled Parenting Project, which can be a helpful resource and support group online, and you can just find their website. But that's an area that is definitely impacts a lot of people. These are young women, right, with POTS, and so it's a very common area that's a challenge. And then on and on. So I'm actually not going to go through each of these, but those are just some other examples, as I mentioned before, of activities that you can specifically talk with someone. A lot of people don't know there's a person in healthcare that's actually supposed to help me with this stuff, and that's exactly what we do. We're like the practical problem solvers. On this slide, I wanted to show a variety of options for seating. As we know, being upright is not always the easiest thing for someone with POTS, and so many of these are sit to stand chairs, which don't have to be medical based or wheelchairs, although that is an option for some power chairs. You can find these through a simple Google search, but some of the brands on the bottom row are Capisco with a C, that medical professionals chair on the left, which is nice. It goes up and down, it has wheels, and it has an option for a foot bar or footrest. You can also get a much cheaper, kind of bar stool, but some of these are nice for wheeling around your house. The middle chair on the bottom is the Vela chair, and I think that might be the one on the top right too, a different type of it, but this is one of these actual sit to stand and elevating types of chairs, which are really nice. I know there's one vendor in Florida in the United States. They're actually based, I think, in Denmark, but they're all over the world. So wherever you are, that might be a good option. And you can wheel around your house, and then or your workplace or wherever you are. And then on the bottom right, you'll see kneeling chairs, which are advertised as like ergonomic chairs, but I think they're kind of nice as an option for kind of a forward posture if you sit with your feet behind it, or to elevate your leg like she's doing in that picture, just as an alternative to another type of chair, and good for your posture to have a different position. And then on the top, you'll see some stools, or active seats is sometimes what they're advertised as. Fortunately, with the pandemic and working from home, there's a lot more of these types of resources out there. Yeah, those are some good options. You'll also see an anti-fatigue mat on that top left one, which can make a huge difference for people standing. We saw that falls were happening in more than half of the population that we sampled. And so I wanted to include some information here on ways to prevent falls, especially because these are likely different than a typical older adult's fall that we see. You know, that's what we see the literature about. So first, you want to determine the risk, including warning signs and triggers. Risk factors might be physical risk factors is one category. So things like impaired balance, lightheadedness, any of those symptoms that you might be having. Environmental factors would be things like a slippery shower or a loose rug. You can see in that bottom picture, it's basically a recipe for a fall. And the third category would be behavioral, such as ignoring those warning signs, or things like that you might be able to kind of change with your actions. These are especially important to consider in low lighting environments. So for example, that bottom picture, imagine in the middle of the night, you don't remember that the shoes are there, that the rug looks like that, and that the comforter is on the ground, and there's lots of places to trip there. And then also important to remember this in new or unfamiliar environments. So if you're staying at someone else's house, or if you're in a hotel environment, you might be thinking like, well, it's not that I'm going to slip and fall more likely than someone else. But if you have a difference in your equilibrium, that sense of balance, if you're having heart racing and other symptoms, sometimes you are more at risk for kind of not being able to catch yourself as easily. Just like someone who has impaired balance and they have their glasses off, well, now they don't have their vision to be able to compensate for their balance. And so try not to dismiss, but like taking in mind all of these different factors together. And it's also important to keep these in mind when you have a medication change, or when you have an illness, because that often makes POTS symptoms worse, or if you have a lack of sleep or limited sleep, which I'm sure nobody watching this has ever had poor sleep, right? That's not common at all. And then the next step would be to make a plan. So making a plan for how to prevent falls and what to do if you do fall. How do you get back up? Who do you call? I often tell people to use the Hey Siri function on their phone, so that if they were to fall and their phone was far away, they would be able to call someone. Or in your bathroom or somewhere you're more likely to fall, to have a pull alarm or something. You don't have to pay for a subscription. There's just loud things you can buy at the store that will siren and cue someone to come help. And then you might consider options for seating around your home, including in your bathroom and definitely in your shower. Bathrooms specifically are high risk places for falls due to increase in symptoms because of the heat and the standing and the poor ventilation, but also they're slippery. And so having grab bars that are secured with anchors, not grab bars with suction cups. And then a shower seat or a tub bench is recommended, and specifically one that's medical grade to ensure your safety. And then you might also want to add grips to the bottom of the shower floor. I'm so sorry. I don't know why. My throat is so tickled. Okay. And then you want to practice falling and getting back up from the floor. And so a therapist can help customize this and do this with you to minimize your risk of injury. And then lastly, you might consider an assistive device such as a rollator or walking poles to increase your stability if you're still at risk for falls. And if balance specifically is a challenge for you, then you might consider an evaluation with a vestibular audiologist who can do some testing and or seeing a vestibular therapist, so a physical therapist or a vestibular occupational therapist who specifically treats balance issues. All right, we're almost to the end here, and then I'm excited to answer your questions. So a falls prevention plan, this is just a copy of what mine looks like. And so, consider creating your own and thinking through what are some of those elements, those physical, behavioral, and environmental aspects that might be contributing to falls if you've had a fall or if you're afraid of falling. Routine is important for a lot of folks and for a lot of reasons, especially when it comes to sleep. So the photo on the left is sort of a joke, and I hope that some of you laugh at it and don't think I'm crazy, because it doesn't need to be this thought out and this regimented. You don't have to have this perfect Zen life, but keeping certain elements of routine consistent and doing so in a consistent and thoughtful way can be helpful for increasing your success. It can help with circadian rhythms for your sleep, but also routines can help with cognitive functioning or minimizing that brain fog. And then also it helps with preventing symptoms if you get a good routine going. So back to this slide on evidence-based practice. We now know a bit more about what the patient experience looks like. And now you have some more insight into how clinicians' expertise can be beneficial in matching up with what you already know. All right, so the $1 million question, maybe, hopefully you're interested in seeing an OT, but how do you find one to customize all of this? I wish that I could tell you it was easy. But at this point, not everybody knows about POTS, and not every community has outpatient OT readily available. I'm only able to see patients in my state, and I'm actually not taking any patients right now because my wait list is so long. But there are more and more therapists every day with expertise in forms of dysautonomia. So I'd recommend starting with a Google search, asking around your support groups. If you're not in a Dysautonomia National support group on Facebook, you should join one. If nothing else, just to ask questions and look in the search feature. And talking with your medical providers, because there's a chance that they know someone. Specifically, I would look for someone with expertise with neurological conditions or working with people with chronic conditions. Even if you don't have access to someone with either of those specialty areas, if you can just find someone who's willing to learn and work with you, that's often enough. We've got more and more resources out there online for OTs, including some continuing ed resources that they can find that I've done and that other therapists have done online. And so if they're willing to learn and listen to you as a patient, and you already know so much, combining those two heads can sometimes produce some really awesome outcomes. So if you would like to look at any of the resources that I have available, this is where you can find me. And I'm building on these to try and help more people. But I'd love to take questions whenever you're ready. And this is my thank you slide. Tegan, is it okay if I run and get some water really quick?
Yeah, go for it. Yeah, sure.
I don't know why it's doing.
So just a reminder, I'll try and get to as many questions as I can. We only have about 15 minutes, but you can use the Q&A button, and it's on the bottom right side of your Zoom screen. So yeah, you can enter those on there. And like I said, I'll try and get to as many as I can. And just a reminder that we'll share Emily's slides. So if you have, there's a couple questions about the fall prevention plan, and we'll be sharing those slides later, so you guys will have access to that. So good. All right, Emily, you feel good? You ready?
Oh yeah, I'm good. I'm just laughing at how crazy I've been fine all day. Anyway.
Let's see. All right.
Oh, should I stop?
So yeah, that's fine. Yeah, you can stop sharing. Okay, so Emily, so going back to your research a little bit, looking at your research as a whole, what do you think is the biggest area of outstanding need that POP patients have that either isn't being addressed or isn't being addressed enough, that you think could be addressed with an occupational therapy approach?
Mm-hmm. Yeah, well, so my first thought is with like research and learning more is cognition. I mean, we have to figure out what is going on and how we can help people. And just kind of some insight into my own perspective on it is I really see once a lot of the POT symptoms are treated and blood flow is better and a lot of those other things start to improve, cognition improves to a degree, but it's not the whole answer. And so that's an area I think we need a lot more research in. But an area that my patients most often come to me that isn't addressed, and I feel like I really have something to offer them, I think is probably fatigue management. Just in terms, I mean, it's not like I get people, all this energy at the end of the day, but it is so prevalent. I mean, pretty much every person with POTS that I see has pretty significant fatigue. And so figuring out how to restructure the day, get accommodations at work or school, and yeah, using those concepts for energy conservation to save energy, I think is a big area that OT can really help with.
Would you say that that's one of the top treatment strategies for fatigue management, is just pacing and managing time and that sort of thing?
Yes, fortunately or unfortunately, right? It takes a lot of work on the patient's end. And that's definitely how a lot of these kinds of things, self-management, right? A lot of it is working with therapists and then you kind of going off and trying to implement those things. But the goal being that we make pacing and not just pacing, but conserving energy. So ways to work smarter, not harder, of changing the way you do things, making it realistic and fit into the patient's day versus just like you gotta count all the how much you're expend. I mean, sometimes it's too hard to approach yourself, I think.
Yeah, we really hear that a lot. As far as your data, were you surprised by any of the data that came out of that, either the first study or the second one? For example, I wasn't really surprised by this, but more saddened of how many folks feel like they have a level of function of less than 5. Is there other data that just really stuck out to you? Are you still there, Emily? I'll give her just a second. So it looks like Emily's having a little technical difficulties, so we'll give her just a second to hop back on. Yeah, there we go.
Sorry.
There you go.
So yes, I was very surprised. I actually was more surprised at the falls. I didn't actually think that we were going to see half of people having falls. I think because it's not traditionally a syncope diagnosis, and so but I guess it shouldn't have been surprising that within a year people were falling. And I also I wasn't hugely surprised, I think, by the level of function, but it's always hard to with knowing who you're sampling, and people who are like, don't really have to see anybody or be in any groups anymore for POTS. It's kind of tricky, but the patients that I see, I think that it matched up a lot with the patients that I see in terms of that level of function.
Yeah, that makes sense. It's good that you have that interaction both with your patients and through your research. I'm sure you hear a lot of these things from your patients. So let's see. So the discrepancy between people getting care from either occupational therapists or physical therapists and people, the need, obviously, this huge need cognitively and in other ways that they could use it. Can you speculate a little bit on that discrepancy, and why do you think people aren't getting that help? Is it a lack of awareness that that's an option for them, or that might be helpful? I know for some folks, there's a little bit of fear when they picture like physical therapy or occupational therapy. They think like tough exercise or like a hard trainer or something. So do you want to speculate a little bit or theorize at all what you think about that?
Totally. Yeah. So as I mentioned, we asked, did you get who got a referral to therapy, and also who actually got therapy? And it was basically the same number. So people aren't being referred to therapy either. So I don't think it's necessarily that patients aren't going if they are referred, although it could be that the doctor, whoever provider asks, do you want to go? And they say no, if they don't want to. But I agree that physical therapy is often really intimidating for people with POTS. And, for good reason. I think in the past we didn't understand it well enough. And some therapists, were pretty aggressive in terms of their approach to returning to exercise. I don't think that's the case, fortunately, as often now. There's so much more education happening. It's not to say it wouldn't happen, but I think OT is a little bit more approachable sometimes for people. And often I encourage doctors who say, I've tried to get patients into PT and they had bad experience or whatever, send them to me first, and I can introduce them to some kind of very preliminary exercises that I know they're going to tolerate pretty well, and that we build up this foundational level of strength, and then we can move on to physical therapy and go from there with a knowledgeable PT.
Someone asked, can an occupational therapist help with mental health impact of POTS? What do you think about that?
Yes, it's funny. I don't ever talk about it in my talks because it's probably half of my work, probably half of my sessions. And almost for the same reason, sometimes, that psychology is intimidating for people with POTS because they've been told that it's all in their head. And so I don't want to go see a psychologist. And I am 100% pro psychology counseling for POTS. And I also really understand why people are nervous about it. I think any chronic condition, it just makes sense to be able to process it with someone. And so when people come into my office, it's often the first time they've met someone who actually knows much about it. And so it's like validation, this isn't in my head. Oh my goodness, you understand. So that kind of turns into, a lot of times just like very cathartic, like, you got it, and like, there's tears every single day in my office. Not every single person every day, but we use a lot of tissues. So I think it's productive processing in the office, and then coupled with yeah, I mean, how many times does your heart rate increasing cause you to feel anxious? Not, necessarily that you have anxiety, but it causes that anxiousness because it goes with it. So finding strategies, like I use a lot of breathing and biofeedback to learn how to regulate the nervous system so that you don't have that same heightened like hypervigilance of kind of this like fight or flight kind of a mode. So that is in part, sort of mental health, sort of, it's very like medical, but yes, lots.
Kind of on a similar topic. So you mentioned when you were talking about some of the different aids, folks struggling with the feeling of spoiling themselves on some of these things. And as you know, there's just so much stigma around using a lot of these things. On top of that, what would you say to those people that are kind of struggling with those things? Like, should I buy a shower chair? Should I, do I need help with my socks? What do you think?
Yes. Yeah, I think there's such a line too, right? Of becoming like my whole house is turned into having all of this medical stuff versus, where can I kind of blend it in? And the shower chair is funny because I don't have a study to show this, but I've been told that you can save like 2/3 of your amount of energy showering sitting down. So it takes 1/3 of the amount of energy. So to me, if you can do that, nobody even knows you're sitting down in the shower. I mean, maybe if your friends come over and they have to use the shower, but the reality is I see that as a way that you can hide it, pretty well. And then you can go out with your friends because you have that much energy and you can do other things. Or, maybe not go out with your friends, but you could play video games or whatever it is that you're able to do. And same with kind of spoiling yourself with those other tools. I mean, some of them are really expensive, but like Christmas is coming. Like my robot vacuum is like less than $100 and it has held up for a year at least. So I think if it empowers you to be able to do something else that you couldn't otherwise do, then yes, that is the reason to use something like that. And then hopefully it doesn't feel like babying yourself. But there's always going to be people who don't understand. And we just take a deep breath and try and educate and hope that one day they do.
Yeah, I totally agree. I think there's this thought that the more sort of things like a shower chair that you use, you'll do less. But exactly like you're saying, Emily, from what I've seen in my own personal experience, you end up doing more and it allows you to do more things that you couldn't do before. So it can be really awesome and important. So let me see I'm just going to cut a couple more questions here. Okay. Somebody's asking is about the Chop Levine exercise protocol. Is that still a recommended approach? Is there additional ones to consider from an OT perspective? Is there a better way to, or is there a better time of day to do it as well?
So that's the only exercise approach that we have research evidence on at this time. So you saw the evidence-based practice diagram, and I think that it is completely dependent on the person and the therapist's experience. And then there's that piece of that research evidence. So I know a lot of therapists that swear by the Levine or Dallas protocol and use it with all of their patients. And then I know that a lot of my patients have felt like they failed because they can't keep up with it or it's too hard to start with. And so I like to use it as, this is a framework. It has some great, that CHOP one that's on the Dysautonomia National website has some great pictures of exercises that I think are excellent to start with. Or there's other ones you might want to start with first. But as far as the calendars go, I don't follow them as strictly because I don't want anyone to feel like they're failing. And so if you can find a way to be motivated, I think that like 4 to 5 days a week, find yourself doing something, like get yourself doing something at least 4 to 5 days a week. And I like the strength and cardio alternating and really trying. So there's a lot that I I do like. Time of day totally depends on the person. Most people, I shouldn't say most, a lot of people don't do well in the mornings. And so if you don't have good symptoms, if your symptoms are worse in the morning, don't do it in the morning. But you might not want to do it right before bed either, because that might kind of mess with your circadian rhythm. So trying to find that late afternoon or, before dinner, whatever works for you.
So I think we'll do one more question here. Several folks or you were talking about some of your patients have service dogs, and a couple folks are asking about specific ways that service dogs can help folks with POTS.
I wish I had one of my patients on here because they all know so much more than I do about the service dogs, but I love when people can share with each other about what their dogs do. And I think there's a Facebook group, so I would ask on there too. But I know that one of the big things is they can pick things up for you. So people who drop their keys or drop something on the floor, it prevents you from having to bend down. They can serve as a balance I forget what this term is. People are going to laugh, but it's like a balance stabilization point for you as you're walking if they're big enough and have a harness. They can do deep pressure proprioceptive input. So same kind of thing as a weighted blanket or a weighted lap pad. They can lay on you and serve as a calming input for you in that way. They can alert, obviously, and go get somebody if something happens. They can sense like seizure activity. And so if you're having some of like the tachycardia, I have one patient actually who her dog can tell when her blood pressure or heart rate changes. So good or bad, because sometimes it's like, we don't want to obsess over that heart rate, but he alerts her and then she can kind of check and then decide what to do from there. And if she needs to, take some salt pills, drink some extra water, whatever it is. And they can carry things, which is so nice with their little vests. People will put extra salt pills in there, or they can carry their water bottles, that kind of thing. So, and tons more. I'm way understating what they can do, but.
Yeah, it sounds like we need to have a talk just on that. We should have someone come on and do a DI webinar about their service dog. That would be awesome.
Yeah, totally.
Okay, well, we're just about out of time. So thank you so much, Emily, for being here.